Hi everyone. I want to go over this, PowerPoint here on pleural effusions. And we talk about pleural effusions. Pleural is the space around the lung. Effusion is a collection of fluid. So this is a collection of fluid that surrounds the lung. So pleural effusion is a disease process which can cause fluid accumulation in the pleural space around the lung, sometimes can restrict the lung expansion. So it's important to kind of review a little bit of the anatomy. So we take a little cross section here of the space or the pleural space around the lung. You can see this is the lung right here. And then right on top of the lung is a layer which is called the visceral pleura. And anything that says visceral is something that covers an organ. So that covers the lung. And then there's this white plate right here, which is the pleural space. So there's a little bit of space in there. It's a thin space with a little bit of lubrication in here. And then on the outside, inside the chest wall is the parietal pleura. And so inside these pleuras is the pleural space. Inside here is some fluid, only maybe about 10 milliliters of fluid, but it's very similar to interstitial fluid, and it kind of makes it slippery in here. So when lungs expand, that there's some lubrication and slipperiness in here for the expansion and contraction. So this next slide right here kind of is a breakdown of that, and this is the pleural space right here. Right here is the visceral pleura, remember again, on the lung, and the parietal pleura, which is on the chest wall right here. So in here is that little pleural space, and fluid collects in here, and it has to drain, so it drains through the lymph nodes right here. So there's always a little bit of fluid that leaks in here, and again, it's basically interstitial fluid needed for lubrication, and then it gets drained through the lymphatic vessels. So sometimes things occur and there's too much fluid that comes in, and sometimes things occur that may block these lymph vessels and fluid can't drain out, and either one is going to cause an accumulation of fluid in here. So fills with fluid, lubrication, slippery with protein-like albumin, and like I said, it's essentially interstitial fluid right in here. So it's just important to kind of know where we're talking here. We're not talking about in the parenchymal or the actual lung. So this slide right here looks a little busy, but again, excessive fluid in the pleural space. Why? Why is there pleural fluid in the pleural space? Too much fluid is produced by the body. We're going to talk about what causes the body to produce too much fluid that's going to leak into the pleural space. And two things we're going to really focus on here is that when we take a look at that pleural fluid, is it a transudative fluid or an exudative fluid? Because this is how we can, this assists in the diagnosis as far as like what caused the pleural effusion. Or lymphatics, like I said, can't drain effectively, and so it kind of accumulates. They have lymph that just accumulates, that interstitial fluid accumulates in that space. Let's talk about transudative fluid. It occurs, so transudative pleural effusion causes, and it occurs because fluid starts collecting in the pleural space. Why? Because of two reasons. One, an increased hydrostatic pressure, and you know that hydrostatic pressure basically is example of it. It is basically blood pressure, right? And hydrostatic pressure is a pushing force. So when there's increased hydrostatic pressure, the heart can't pump blood, and when the heart can't pump blood forward, it backs up, the fluid backs up into the pulmonary vessels, and hence somebody can get an accumulation of fluid because of an increased hydrostatic pressure. And the perfect example is congestive heart failure. So the most common cause of a transudative pleural effusion is heart failure. We see it very, very often. The second thing that can cause a transudative pleural effusion would be something that would cause a decrease in oncotic pressure. So albumin becomes low. There's a reason that there's not albumin in the blood. So when the albumin or the proteins in the fluid decrease, the pressure becomes low, and then the fluid leaks out. What are some things that cause a decrease oncotic pressure? The two most common things, number one, cirrhosis. Keep in mind that albumins are made in the liver, and if they don't have any if the liver's not making albumin, there's no albumin in the blood has a decreased oncotic pressure. The proteins aren't pulling, keeping that fluid in the vessel, so it just leaks out. It seeps out, and it seeps into a lot of areas, right, for somebody with cirrhosis in their belly, and it seeps into their pleural space. The second most common reason would be nephrotic syndrome, because all the proteins are lost in the urine. Therefore, there's no proteins in the fluid, and that fluid just becomes too liquidy and it just leaks out. So transudative, make sure you know the causes. The second type would be an exudative pleural effusion, and the cause is generally because of inflammation of the pulmonary capillaries, and they just become more leaky. So the fluid and immune cells and large proteins like LDH, which every single cell has, just leak out of the capillaries. And there's many causes. Causes can vary, but some common reasons that somebody would have an exudative pleural effusion: trauma. Probably the most common here would be a malignancy. Okay, there's some kind of cancer, inflammatory conditions like rheumatoid arthritis and lupus, an infection like pneumonia. And this is another common reason that somebody can have fluid that backs up, right? The infection kind of leaks into the pleural space, and the fluid, when the fluid gets drained, it has these inflammatory / infection cells in them, and so they become an exudative. It's an exudative pleural effusion. So common causes of that: malignancy, infection, pneumonia. Can spread to the pleural space like an abscess. So what happens is when that bacteria leaks into the pleural space, it's a kind of a closed space in there, so it walls off kind of like a big giant abscess. And so these fibrous walls form, and when these fibrous walls form around it, there's this big pocket of infection, which we call a loculation in there. You may have heard that term. So transudative pleural effusion causes, exudative pleural effusion causes. Important to know the difference between the two. So there's another one called a kylothorax, or a lymphatic pleural effusion. Lymphatic fluid accumulates in the pleural space because the thoracic duct is disrupted. The most common cause of a kylothorax is there's just damage to this thoracic duct, and so the thoracic duct can't drain that lymph from that pleural space. It gets damaged because of some kind of surgery. And another thing would be tumors. They could compress, like maybe a mediastinal tumor that can compress that thoracic duct and just kind of compress it shut. This is a little bit of just kind of what I said. I want to go through it quickly, but I want to review kind of the difference. Increased amounts of fluid within the pleural space, either transudative or exudative, and then we'll talk about the kylothorax and then something a little different. So transudative, increased hydrostatic or decreased oncotic pressure. These are the common causes: congestive heart failure, cirrhosis, and anything that causes a low albumin, just hypoalbuminemia. An exudative, increased production of fluid due to, why is the fluid accumulating in the pleural space? There's an abnormal capillary permeability or a decreased lymph clearance from the pleural space because of something that has infection or inflammation. So any type of infection, pneumonia, malignancy, any of this that can cause inflammatory cells. So it's not like a clear transudative, it's a cloudy looking fluid. Okay. Kylothorax, remember, it's an accumulation of the lymphatics in the pleural space. And a parapneumonic pleural effusion is a pleural effusion that forms in the pleural space adjacent to a bacterial pneumonia in the lung. So again, that bacteria leaks into that pleural space. It's exudative, but it is due to a pneumonia. Found in at least 40% of people with bacterial pneumonias get a parapneumonic pleural effusion, which is an exudative. Usually is small, and they can resolve with antibiotic therapy. If the bacteria invades the pleural space, a complicated pneumonia or an empyema may result. And what the empyema is it is an exudate, so it's an exudate that accompanies an infection, often some type of pneumonia or infection in the lung, and accumulates in the pleural space, and it's just like a pasty, thick, it just gets really thick and pasty. They try to drain it with a tube, and sometimes it has to be removed by surgery because it gets so thick and pasty. So symptoms, let's talk about some symptoms real quick. So dyspnea, sometimes their dyspnea becomes a little bit more common when they're laying down, and maybe some pleuritic chest pain, but see how this fluid starts accumulating and accumulating, and as it accumulates, it compresses this lung, and this total lung capacity right here, this volume gets smaller and smaller and smaller, and they get short of breath. Some physical exam findings that are important to know, they become tachypnic, especially with exertion. Why wouldn't they? Look how small this lung has been. Decreased breath sounds in the affected area right here. If you put your stethoscope right here, you're not going to hear any breath sounds because there's no lung there. It's just fluid. If we percussed right here, remember percussion in lungs should be a resonant sound, like kind of like that's like a hollow sound, but we get dullness on percussion. If we percuss anything with water, it feels dull. So that's important to know. A decreased tactile fremitus, and tactile fremitus is a normal finding. The chest wall, remember, it vibrates if you put your hand on your chest when you're talking, like I'm doing right now. We can vibrate when we're speaking. And if there is a pleural effusion, there's going to be fewer vibrations because of the fluid. So tactile fremitus is less. Pleural friction rub, possibly. And if there's an infection, certainly they can have a fever. So how do we diagnose it? So we can see it on a chest x-ray, increased amount of fluid between the visceral and parietal pleural membranes, blunting of the costophrenic angles. So costophrenic angles is where this diaphragm meets the chest wall. So you can kind of see how it's nice and pointy right here. And that's the way it's supposed to look, but you can't see the costophrenic angles right here because there's fluid in here, and you can sometimes see like a little meniscus pattern right here, like fluid in there. And you can see that that's what we call a blunting of the costophrenic angles. If the fluid becomes so much and it pushes and pushes and builds pressure and pushes on the lung, it could cause a tracheal deviation if it's big enough. This is just kind of like the chest x-ray, or just kind of looking at it. The fluid's going to move with gravity. So if somebody's upright, you can see, like we just saw in that x-ray, this is where the pleural fluid is. If they're laying supine, and we would do an x-ray supine, we would see the fluid all kind of flatten out again because of gravity. So a thoracentesis is done to remove the fluid. So we're going to remove the fluid for a couple reasons. Number one, for diagnostics, so we can send that fluid to lab and find out if it's a transudate or exudate, which would lead us to our diagnosis, or just to remove fluid to relieve symptoms. So sometimes patients become dyspneic and they start having respiratory symptoms, their SAT start dropping. So we got to get all this fluid out of there so that lung can expand again. Simple bedside procedure with imaging guidance that permits fluid to be rapidly sampled and visualized. So we send it for an analysis of the fluid along with the clinical presentation. That's how we diagnose right there. And then this is just kind of a cross section of the needle insertion site going through the intercostals right here, right above the rib, into the pleural space. And then the fluid is removed from the needle there. So as far as pleural fluid analysis, something important to know is once we do thoracentesis, the fluid is sent to the lab. We need to know if it's a transudate or an exudate, right? It matters. So it matters because that's how we know what the cause is. And if it's something that's an exudate, that's something a little bit more serious than something that's just transudate. Transudated fluid looks clear, exudative fluid looks cloudy, lymphatic fluid is filled with fats and can kind of look a little bit like milk. So distinguishing between transudative and exudative pleural fluid, we use what we call the Lights criteria. And you have one of your case studies is on the Lights criteria. So to diagnose or to say that somebody's pleural effusion is exudative, the fluid is exudative, you have to take a ratio of two things. First of all, we have to get the pleural fluid protein. So when that pleural effusion fluid is sent to the lab, they get a pleural fluid protein. They measure the proteins in it. We also have to draw blood, serum protein, and we get that lab result. We make a ratio, whatever the number is for the fluid the pleural fluid protein divided by the serum protein. If that's greater than 0.5, we call it an exudative pleural effusion. Or we get a fluid LDH and a serum LDH. We do the same thing. This is a ratio. This goes on top. This goes on the bottom. You divide it. If this LDH is greater than 0.6, we know that it's an exudate, or it's an exudative pleural effusion. Or if the fluid LDH is greater than 2/3 the upper limit of the serum LDH. Any of these things would indicate that this person has an exudative pleural effusion, which again becomes very concerning as to what's going on. Is this something that is serious? A little bit about treatment: removing fluid and treating the cause. So if somebody has a transudate pleural effusion because they have heart failure, okay, well, diuretics, a sodium restriction. If it's small enough, it doesn't need to drain. It'll drain himself with this